Good afternoon, everyone, and welcome. I'm Dr. Kathy McLaughlin, co-chair of the ACS National Roundtable on Cervical Cancer's Self-Collection Work Group, and I'll serve as today's moderator. We welcome you to the second of a three-part webinar series on self-collection entitled HPV Self-Collection System Readiness and Tracking. And we really have a great webinar in store for you today with a lot of real-world examples and experiences to share. Before we begin, I want to share a few housekeeping items. Today's webinar will be recorded, and that link to the recording and a PDF of today's slides will be shared with all who have registered. In addition, the recording link will be posted on the ACS website in the next few days. If you have any issues during the webinar today, please use the chat. If you have any questions for the presenters, please use the Q&A. To ensure there are no disruptions during the presentation, all participants have been muted by the host. We have a number of presenters today, and to ensure time for the Q&A, I'm going to provide just a quick introduction, and you can read their full bios in the chat. Today we have John Lynn, who has worked for over 20 years on cervical cancer-related studies and clinical trials, managing large NIH and industry-sponsored projects, specializing in HPV testing and cervical cancer screening. John is joined by Cassie Caravello, Quality Access Program Director at Texas Association of Community Health Centers. Also presenting is Sarah Zumbido, a registered nurse and EHR support analyst at the Community University Healthcare Center, a federally qualified health center in Minneapolis. And finally, Dr. Carolyn Hawley, a family physician and medical director at Health Point Community Centers in King County, Washington, is here with us. I'm going to go ahead and turn things over to John.
Hi. So first of all, there's a short poll that will show up, and if people could answer that. And so I want to talk about the presentation today. The objectives are one, so that you can understand key QI implementation project best practices for initial planning, buy-in, and engagement. And by the end, also, you'll understand key necessary components to be ready to implement HPV self-collection. And the third thing is to feel motivated and empowered to implement HPV self-collection. So now I will go ahead and hand it off to Cassie with the tag. Go ahead, Cassie.
Hi, everybody. So I'm Cassie Caravello. I work at the Texas Association of Community Health Centers. And I just wanted to tell you how excited I am about you being able to add HPV self-collection to your toolkit in order to reach your quality goals, your clinical improvement metrics, et cetera. So we know that this is a moment of great uncertainty for health centers and in healthcare in general. Whether your state expanded Medicaid or didn't expand Medicaid, lots of changes are coming, and health centers need to be more wise than ever about their staffing, resources, and the workflows that they choose to use, right? So one strategy that I really believe will help health centers is getting as prepared as possible, being as successful as possible in their value-based contracting, right? And a big part of that is success in our HEDIS metrics. And we know that cervical cancer screening is one of those priority measures in HEDIS. And so really having another tool in your toolbox to get to that cervical cancer screening goal in those contracts is HPV self-collect. And so we'll talk about that a little bit today. I also want to mention how often when we're doing QI projects, do we just have to rely on kind of incremental improvement, shaving off a few minutes here and there, or making a workflow like a little bit more efficient? HPV self-collect is what I would consider, unlike an incremental strategy, it's a completely disruptive strategy, right? Like I said, it's a completely new tool. It opens the door to reaching patients you weren't able to reach before with this screening. So I really want you to think about that and the opportunity this could bring to meeting some of the goals that your leadership really, really, really cares about and could lead to additional financial sustainability for your organization. Okay, so next slide. So you've probably heard lots of QI presentations in the past. You know about PDSA cycles. I'm not going to harp on that. What I really want to talk about today is kind of those soft skill pieces the buy-in, keeping buy-in from the teams that you're actually asking to take on a whole new set of tasks or take on a new workflow related to HPV self-collect. And so some of the, ideas that I have for how you can do that are kind of listed here. And so I'm going to go through them quickly and then in a little bit more detail in a moment. So really, as you're embarking on a QI project, a QI initiative, you really want to build a cross-departmental team. I'm going to talk about an example of what that could look like, but you need to bring together people from different departments to give you diverse perspectives on the challenges and find good alignment across the organization. And so you want to have a small group of 3 to 5 people who are going to really take this on and think through all of the issues, right? You also want to consider who the stakeholders are beyond that group. Who are the key players in different departments that can make or break your success? Who is often not brought to the table in decision making that we need to make sure their voices are represented? You need to assess the organization for where is the alignment? Who else might care about this? Who else's goals can I help to meet if this is successful? What are their motivations and what are some of the myths they might have about HPV self-collect that we're going to need to address early on, right? We want to know who might be a champion for us and identify who those hesitant people might be and really pull them very strategically into our approach and our process. You need to get all your technical ducks in a row and anticipate what the challenges might be. And so I think John is going to talk to you about some of those pieces, and there'll be a future webinar to talk through those pieces. But you really have to think through all the kinks that might come up, right? When it comes to your EHR, when it comes to lab, et cetera. Of course, this is where the PDSA piece comes in, right? So you want to pilot this on as small a scale as possible so you can work out some of the challenges before putting it out to your full organization. You need to think through and be very thoughtful about your communication, right? And I like to use the 7x7 approach. So we often think we sent them an email. Now they know what to do. I would challenge you to think through adults need to hear things 7 times, 7 ways to really retain that information. And so when you're talking about staff taking on a new task or a new workflow, when you're talking about offering patients a new strategy for preventive care, they might need to hear it 7 times, 7 ways in order to accept it. And then finally, whoever you've communicated what you're going to do, who you've collected feedback from, you need to close the loop with those folks. Let them know, was it successful, where we are in the project along the way. Don't forget those people that you had to pull in the beginning or that you informed in the beginning. So next slide, I'm going to take you through just a brief example of what the first kind of pieces of this can look like. If I could get the next slide, please. Okay, so if we were just taking an example of a health center I might be working with, when I talk about that core team, maybe the QI director is the lead, but then I'm also pulling in the operations manager or the chief nursing officer as my other key players in this core team because they're going to help me think about things that I didn't think of, right? Recognize who the key stakeholders are. Maybe it's a CMO who is hesitant about this, or the COO who's concerned about the logistics and the workflow, right? Clinicians who don't know necessarily like how to pull HPV self-collect into their day-to-day work, or MAs who are going to have to be doing that work. So we really need to think through who our stakeholders are and understand where alignment might lie. So what are our managed care organization's HEDIS goal for cervical cancer screening? And how can we make sure that everybody who knows we want to take this on know that we are going to help them meet that goal, right? We need to understand the access challenges. And maybe this is a new way to bring, patients in for cervical cancer screening, not filling up appointments that don't necessarily exist, right? We know that a lot of time the wait for a certain type of preventive appointment might be long. And so we could potentially take care of that screening today, right? And so HPV self-collect could address some of those access barriers. It helps address concerns about patients missing appointments. The more we can get into the visit today, we're not delaying that for a future visit. if we're doing pre-visit planning, how does this intersect with that? How does it align with it? How do we make sure that clinicians on their scorecard know that this is a way to allow you to meet that cervical cancer screening goal on your scorecard just by, making sure the patient gets that screening in the clinic today? And then understand and dispel those myths. So I know other folks on the call are going to talk about this, but that, ensuring people know that this does count towards UDS and HEDIS metrics, that it's not a threat to women's health department or team revenue, right? That we're really trying to capture here patients that that wouldn't have necessarily followed up or gone to that women's health appointment. And it's not a lower quality of care, which I think is going to be one of the buy-in barriers for some of our, clinician stakeholders. Next slide. And then this I kind of just see as a checklist of things to consider when engaging staff. So how are we actively listening to our care team members? What I like to do is gather some of our stakeholders on the front line and get them to do a root cause analysis. What are all of the reasons why patients don't get their cervical cancer screening, right? Traditionally, and have them think through the challenges and then them think through the possible solutions, right? Also having the care team map out the workflow, what it looks like today and what it could look like with this new intervention, right? Or even just sharing your plan with care teams and keeping them in the loop in the process. Remember to capture their solutions and concerns. Recognize that feedback is a gift. So if people are telling you things you don't necessarily want to hear, reframe that for yourself as a gift. So glad that they're telling you right now instead of waiting for you to have rolled out a potential plan to hear some of that feedback or those challenges. And then as you engage people, you may notice that champions emerge. And so you need to tap into those people to be your early testers, to be the people who convince others in your organization. Of course, as I said, you need to assess the technical readiness pieces. And so that's going to be your checklist that John's going to talk to you about in a moment. As you're doing your PDSA or your pilot, make sure you know what you're measuring. As you're seeing early success, make sure that the data is showing that and you reflect it back. It helps to increase confidence that this is going to work in our organization, and it helps you work out some of those kinks on the small scale. And then show people the impact on the measure or on some of the other goals related to it. Remember, and unfortunately this gets left out a lot, develop clear and easy training for staff. So I like to talk about the 4 T's, which if you're going to hold people accountable to a new process, did you tell them? Did you train them? Did you give them kind of like on-the-job tools, like quick algorithms that they can refer to on that new workflow? And did you give them the time to adopt it into their process? Consider behavior change. So we have to frame QI as we're asking our staff to change their behavior. And then we're asking our staff to get patients to change their behavior, to adopt a new strategy, right? And so that is a challenging prospect, and you really need to think it through. Are our staff well equipped to use motivational interviewing, for example, to talk to staff about, or to, talk to patients about maybe their readiness or reluctance to do HPV self-collection, and move them along that readiness ruler that we learn about in motivational interviewing. And then thinking about staff and patients' motivation languages, I like to call them, right? So some staff are going to be motivated by seeing the graph tick up, right? Some patients are going to, some staff are going to be motivated by stories. So that story of the, early detection of cancer, that we helped really save someone's quality of life, right? Some staff are going to be motivated by friendly competition of, my team is leading this week in the number of HPV self-tests that were completed. And then other staff are going to really care about incentives, that lunch or that, special bonus for the team. So one solution is not going to work for everyone. You kind of have to have something for everyone. So if you really think that part through, you'll be more successful. But so these are just some of my initial ideas, but I will pass it back to John, and I'll be around in the chat if anybody has any additional questions or thoughts around motivation and buy-in.
Thank you so much, Cassie, for those important reminders on engagement and buy-in. Everyone always usually thinks initially about all the technical things you have to do and all the tools, but really the best workflow is one that people actually want to adopt and do adopt. So that's why, it's very important, all these things she said. Now, I do want to discuss the critical things, like Cassie mentioned, that every health system must do to be ready to implement HPV self-collection. So before I begin, I want to mention a few things to kind of remove or reduce hesitancy folks might have. You might be intimidated by, oh, it's a whole new test, but first of all, you can do it. I've worked with many other groups and they've done it and it hasn't been a horrible process and it's not horribly complicated. First of all, it's not entirely new test. That's a really important thing. It's just an additional option for specimen collection and it's run with the same HPV test. You get the same results components and everything. And then also, you do already provide cervical cancer screening and follow-up. So you don't need to, nor should you, revamp your whole cervical cancer screening workflow. You're just making small tweaks to it for this new collection method. And of course, the other thing I always mention is keep it simple, right? You don't want to be creating a whole new workflow. So next slide. So this is a high-level workflow slide that highlights modifications you'll have to do. And so it doesn't have all the details. That'll be covered in the next webinar. But this is just to remind you that it's not a huge process, or it shouldn't become one. So the top row with the teal colored boxes, that's an existing workflow. And the bottom row shows what you need to change. So going from left to the right, you could see the first gray box you'll see there is that you need to offer it. You need to determine that's an appropriate option and offer it. And then the next gray box over is that you need to perform a special self-collect instead of a speculum exam. So this is actually a time savings here. So it should actually not be complicated there. And then the last one, final one, that is quite important is that about 7% of patients that do the self-collect, they will have a other high-risk HPV positive result, and they will actually need to come in still for a speculum exam to complete a PAP in order to actually complete screening. So next slide. And I do want to, on that red box there, I do want to spend a little time emphasizing that a reflex PAP cannot be run on a self-collect swab. So screening is not complete for those 7% of folks, roughly, that are other high-risk positive that have that result. And this is since PAPs look for cervical cells and HPV self-collect collects vaginal cells. And this is updated in the ASCCP app, though. And in case folks aren't aware, as of October 29, 2025, the app and the website actually explicitly have algorithms management for self-collect. And so, do that update and remind any colleagues that do use the app. If they're using the website, obviously, they'll just see that update. Next slide. Okay, so now let's talk about the critical things that you absolutely do have to be ready to implement. So there are really 4 key things. And there's lab capacity, there's metrics, as everyone, I'm sure you've already thought about this, UDS and HEDIS if you are required to report that. And then there's reimbursement and billing, naturally. And then the last one, and this bit, related to what Cassie was saying, you need a QI team and stakeholder assembly. And there are key folks that you absolutely must engage to be able to do this. So next slide. So the first one is lab capacity. So it may sound obvious, but there are actually a few important considerations here. So the 3 questions that I recommend you ask your lab are, 1, do they offer it? And obviously, if they don't offer the lab test, you can't offer self-collect. And if you use LabCorp or Quest for your lab, you can check on their online test catalog. And you would think that it's offered nationally, but when they roll out a new test, I would recommend that you check that test catalog. For example, Quest covers almost all of the US, but there are little small pockets the last time I checked where they aren't offering it. So do check if they offer it. The second thing is, do they have the capacity to test for your health system's expected quantity? So that's important. Just because they offer it doesn't mean they have the capacity that you need. And the third thing is, do they have sufficient consumables? And these would be the self-collect kits. And it's very important. I've come across this where they have capacity, but they don't have sufficient kits. So those 3 things, do they offer it? Do they have test capacity? And do they have sufficient kit capacity? And since you're contacting them anyway, I would also recommend that you always ask them for the cell sheet. Or there may be another name, just like the packet about the device. And this will give you all the details like test codes and the CPT code and how to order the kits and everything like that. And if you program your own EHR to lab interface, also ask for the build sheet. Your EHR programmer will need that. If you're responsible for that component of your EHR building, just ask for that build sheet now. Okay, next slide, please. All right, so the all-important thing of metrics. So I have good news here. My experience and interpretation and working across multiple states and with health systems, large and small, is yes, absolutely, it is covered by HEDIS and UDS. So most of you are probably aware that NCQA is who contracts or operationalizes, writes those metrics for HEDIS and UDS, all the different HRSA and BCCP and everyone else. So the important thing here is that their prior presentations, if you look at presentations they have, their trainings, their communications, and other communications I've had, the key thing is that the measures are interpreted based on the billing code and the measure specifications. And this is consistent across all metrics and not just cervical cancer screening. The key thing here, right, billing codes are very important. And so in this case, the CPT is identical for cervical and vaginal HPV self-collect. So this is not an issue here. Exactly the same CPT code is used. And for the measure specification, both HEDIS and UDS, if you look at the CCS measure specifications, the language really says, and rightfully so, because they don't want to keep updating with all the technology changes and guideline changes, is that you're doing it by guideline recommended and FDA approved tests. And so in that case, it also does satisfy that. Now for HEDIS in particular, it's actually explicitly, for folks that aren't aware, it's been explicitly covered since 2025 when they had a blanket update saying that member collected samples are considered satisfying measures, as long as the CPT codes and it's consistent with the intent of that measure. And for UDS, my experience with health systems, they don't have that explicit language about member collected samples, but since it does have the same CPT code and it's in guidelines and these are FDA approved tests, my experience with working with health systems that have checked with UDS, with their healthcare authority and everyone else, is that yes, they interpret it the same as HEDIS. And that makes sense because healthcare authorities are responsible for that related to HEDIS and UDS in terms of reimbursement. And if you're not aware, on October 1, 2025, HRSA did put out explicit inclusion of self-collect into UDS, and that public comment closed on 10/31. But unfortunately, due to the government shutdown, it's still under review, but hopefully it will be approved soon. And the last note is on BCCP. So double check with your state. But my experience with talking to healthcare authorities and health systems contacting is that it is included and they interpret it along the same lines as UDS. So next slide, please. So reimbursement and billing. This one is really simple. Like I mentioned before, it's exactly the same CPT code. It's 87626. And if that doesn't look familiar to you, it may be because that's a new code that was rolled out in January 2025. And so your state may still be using 87624. But it shouldn't be a problem because labs do the billing and they want reimbursement. And so they should be aligned with what your state healthcare authority fee schedules are like. I do recommend that you check with your healthcare authority Medicaid fee schedule just to double check to see which code they're using, if it's the new code, 87626 or 87624, and then double check that your lab is doing that because you don't want to have to resubmit claims. Next slide, please. And the final thing is the QI team, stakeholder assembly. You absolutely must engage your EHR programmer, regardless of who you engage, because you need that person to build and connect that order to your lab. And also, you absolutely must engage your women's health team or individual if it's smaller, because those other high-risk positives that I mentioned before, they do need to come in to complete a PAP, to complete screening, which is, to satisfy care gaps and to make sure reports are included. You want to make sure that those folks don't fall out of that abnormal result management pathway. Next slide, please. And finally, I want to say that it's a lot that I kind of covered there, but really it's not that much. You need to contact your lab, you need to check on the CPT code and engage our EHR program and women's health team. And so for the next webinar, I'll talk a lot about the little key things that you should do that we've learned from working with lots of different health systems. And, this list here is kind of those key steps there. And so don't worry, I will get into more of those details next time. And so thanks so much for listening. And now let's go to some wonderful FQHCs I've worked with, and they can talk about their experiences. And first is Sarah Zumbado go ahead, Sarah.
Great. Thank you so much, John. Hello, everyone, and thank you for joining us today. So I'm going to start with a little bit of information about us. So Community University Healthcare Center, or CUC, as we go by, is a single site, federally qualified health center located in South Minneapolis in Minnesota. Founded in 1965, we are the first and oldest FQHC in Minnesota. CUC employs about 145 staff, and last year we hosted about 185 students and learners. So more students and learners than staff, which will be important, what I'll cover here shortly. And in terms of patient volume, we saw nearly 12,000 patients through approximately 49,000 visits and have an operating budget of $25 million. Ocean Epic is our EHR. And Ocean is a nonprofit vendor who has one instance of Epic that's shared among many different organizations in the safety net, has key features to support community health centers, such as our federal reporting. And this is a way for safety net clinics like us to have access to the power of Epic. But it is different from larger academic medical centers or big integrated health systems that have their own instance. Next slide. So we've touched on some of this, but to highlight a bit more about our clinic, our payer mix is heavily Medicaid and uninsured patients, and only about 9% of our patients have private commercial insurance. Language as well as race and ethnic diversity is another piece that makes CUC unique. Greater than 50% of our patients prefer their care in a language other than English. And last year, we recorded 57 languages spoken, with the top 3 being English, Spanish, and Somali. So that's who we are. So I want to kind of transition here and talk about how we actually got involved with the HPV self-swab. So dialing back the clock, in August of 2022, CUC was invited to join the research cohort known as the ISPAR project, which was focused on improving cervical cancer screening amongst Somali American patients and other underscreened populations who face barriers to traditional screening methodologies. We then launched the HPV self-swab in January of 2023, becoming one of the first 3 clinics nationally to offer it as a standard screening option. So this was all before some of the bigger pieces and how this is now coming into the guidelines. So some key factors that made it optimal for us to participate are patient populations, as you see in our slide. One of our learners at the time needed a quality improvement project focused on women's health. mHealth Fairview Laboratory was participating in the research project, and they happened to be our reference lab. And so they were offering the test pre-FDA approval as a CLIA lab-developed test, which would make it available to us via their test catalog. The test code, as John mentioned, the CPT would count in meeting the clinical quality metrics. And the test procedure would be easy to teach because we already did other types of self-collected samples, such as vaginal wet prep. So learner projects are meant to align with strategic initiatives and quality goals, and are often ways by which we can pilot some projects with limited resourcing. We actually chose to launch it as a broader, more integrated approach based on clinical criteria for appropriate cervical cancer screening versus just one population, one test. FDA approval came later in 2024, and now we're seeing guidelines and metrics continue to align as well. With all this work, we continue to refine our own workflows and improve our quality metrics and patient experience. Prior to 2023, we were around 39 to 42% of patients screened, and saw an increase to 47% in 2023 with the addition. 49% in 2024, and this year we're just over 52% to date. I do want to mention self-swab is not the single solution. That's not the one thing that also increased our numbers, but it is giving another option or tool for patients who today may have continued to stay unscreened if not given the choice. So passing over to Courtney. Thank you.
Oh, Carolyn, do you want to go ahead?
Oh yeah, sorry. She said Courtney, so I thought she was talking about somebody else.
Oh, sorry.
Yeah, hello everyone. My name's Carolyn Howley. I am the medical director at HealthPoint. We're a FQHC located in King County outside the city of Seattle. We have 13 primary care clinics and 6 school-based clinics and serve over 100,000 patients. And with the typical demographics of FQHCs, except for we serve approximately 70% of the newly arrived refugees in King County, and our care is also provided in over 70 different languages. So we started a pilot for HPV self-collect with 3 clinics in August, and then had 5 more clinics roll out mid-November, and the remaining clinics are going to roll out next Monday. And the steps to our success that have led our care teams to be actually really excited about this new option, it's been, I think, successful in every way, is we started with a presentation at an all-provider meeting in the summer. And providers were unanimously enthusiastic about the self-collect option. We trained then for the clinics that were going live, we trained providers and MAs separately at site meetings. And in the pilot phase, this was in person. For the full rollout, this is via a video that I made that's played at the site provider and MA meetings. And as we rolled it out with the pilot, we settled on a best practice workflow that includes the providers identifying in their pre-charting and huddle who is eligible for self-collect, and then the MAs giving these patients the patient information handout while they're waiting for the provider. And the MAs have also been really enthusiastic and love telling patients about this option. We developed organizational smart phrases for the AVS and for result letters. As we're going live, we had team chats open for each rollout group that included all providers at those clinics and the MA supervisors, so we could answer people's questions in real time. And we also had the bill developed prior to any of this happening so that vaginal self-collect swab could be ordered easily through care gaps. We did get a lot of questions from providers, especially in the pilot. So we developed an FAQ with 17 questions that include eligibility, ordering, and management. So questions like, why can't a patient do self-collect if they're pregnant? How seriously do we need to take the nothing in vagina for 48 hours rule? Can I have the patient do their self-collect at home? If the result is negative on vaginal self-collect, is the patient due for cervical cancer screening in 3 years or 5 years? And so just in general, it's been really successful. If I still have time, I could just add a few success stories that we've had. One provider had a 41-year-old woman with catatonic schizophrenia overdue for PAP, came in with her mom for medication review. The provider had documented during pre-charting the patient was eligible for HPV self-swab, went over that with the MA. The MA then went in, gave the handout, said she was eligible. This was a new option. And when the provider entered the room, the mom was reading and reviewing the handout and was really excited about the option. And the provider was able to go ahead and place the order easily through care gaps, and the patient got tested. I myself had a trans male patient who had never had a PAP, and we'd actually been talking about self-swab coming for about 6 months. And I was able to tell him in July, make an appointment in August. So he came in, did the self-collect, and felt really great about this. Also had an Afghan patient who said at the visit she wanted to postpone discussion of cervical cancer screening for a year, but when the provider was able to offer her the self-swab option, she agreed immediately and went ahead and did it. So those are just a few success stories that we've had so far, but it has been a just incredibly positive experience that the MAs, providers, and patients all feel great about having this option. So that's what I have. Thanks, everyone.
All right, thank you so much. Just a reminder, if you do have questions, please enter them in the Q&A box. It looks like 8 questions have already been answered, so you can look at those comments as well. We're going to move into a discussion now among the presenters based on these questions. And I wanted to also introduce Andrea Davis, if she was able to call in, and Kelly Casara, who work with Sarah at the Community University Healthcare Center. Thank you to all of our panelists for being here. I know folks are in the midst of answering questions as well, but I also want to know, Dr. Halley, are you able to share your FAQs? 2 people asked that, and I think all of us would love that as well. Excellent.
Yeah, happy to.
Okay, thank you so much. So one of the questions that is in the Q&A still and not answered yet is about what are the best practices for integrating stakeholders in HPV self-collection processes, particularly for communities with members who may not have received past cervical cancer screening or gynecologic care. So kind of best practices for integrating stakeholders.
I can speak to that really quickly, and I'm hoping that some of the folks that are doing the amazing research in HPV self-collect will find some nice evidence-based, quick slogan scripts that we can provide our staff for like the general audience. But I would say, you know your patient populations, and you need to find a way to somehow bring them into the process if there are very local or cultural concerns that you think need to be addressed. And so, do you do focus groups, or health centers have to have 50% board members be patients? So I would say that's also an opportunity. Are there, centering groups or other kind of groups of patients that come together to provide feedback to your health center? So any of those groups you can tap into to get their thoughts on what then come down the pike as some of those kind of like evidence-based recommendations around education, flyers, etc. I would definitely encourage you to tailor those to your local community context using those groups.
Excellent. I think that kind of ties into the next question, or maybe answers it, but that next question was around education techniques that could be used when you're bringing this into your clinic setting to help bring stakeholders on board, as well as patients who may qualify for this option.
Yeah, and I can speak briefly to that. I think it's a reminder to not reinvent the wheel, because most clinics, you probably are already doing vaginal self-collect for chlamydia or gonorrhea or wet prep. And so leverage that. Don't create a whole nother instruction sheet and everything, and use that. And then to what Cassie was saying too is you already know how to engage. I mean, there's obviously specific tailoring for cervical cancer screening, but leverage the way you're already engaging your community and stakeholders. It's not the time to try to recreate a whole new framework.
Sounds good. Anyone else want to comment on that?
I just wanted to mention that I've seen some of the like graphic instructions that are being developed by the group that are working on this, and they're excellent, almost completely graphic. I don't even know if like translation is even necessarily needed. So those are an excellent tool as well. And then just when doing any patient education, like use Teach Back, use, kind of agenda setting, understand what the patient's hesitations or motivations are. So like those pieces play into your educational approach.
I can also add in, so as part of the research project piece of it, the project had multiple translations available for us to hand out to patients to use during education with those pieces. And I will also kind of take it as like we had lots of educational sessions with our providers as well. We had things we hung up in the offices that talked and kind of which pathways, especially because one of the key important pieces is like it is not a first line test for everyone, as was mentioned, right? So there's, bringing people along in that education that just because it's maybe easier is not it necessarily clinically appropriate.
Thank you. Sorry, a couple more just dropped in that I haven't had the chance to read through yet. Could the wonderful panelists, that's very nice, talk more about how to empower HPV self-collection leaders to dispel myths that were previously mentioned? And if you do come up against a roadblock by a stakeholder, how might you handle that if they're seeing it as a threat to traditional cervical cancer screening methods?
Anyone, Carolyn, or I mean, I can, if anyone else wants to jump in too, that's been offering it. But, I think the important thing is to note that it's an option, right? So it doesn't have to be off. You're not switching all of your cervical cancer screening over to that. And it's going to be imperfect, just like any clinical care, it's an iterative process. You do PDSA cycles. And so don't be discouraged if you don't have all of the options, and all of the answers, No one does, even the researchers. That's why there's endless research on it. And there are endless repositories of educational materials. And so, I know that's not a specific answer, but there's lots of research going in on this, and ACS always is working on new materials. And, your peers and colleagues. I always encourage folks to talk to your, neighboring FQHC you're already in contact with.
Yeah. Thank you for having us. I'm Andrea Davis. I'm one of the providers that works at Community University Healthcare Center with Sarah and Kelly. I would say that the HPV self-collect, some patients truly do want a speculum pelvic exam, and that's wonderful, and I support, and so we would execute that as requested. The HPV self swab has been certainly a game changer. We've seen that. We've heard stories, firsthand accounts of that for patients who have really a lot of social trauma, PTSD, from different experiences that they've had. And so this option, when presented to the patients who have had those traumas, have been very readily received for our patients, particularly at Cook with our Somali speaking patients. They're very private. They don't want to be talking about their vaginas. They don't want to be looking at pictures. It's a very private topic for them. And so using the diagrams that have been created, just as a one-on-one, we have folded sheets in the room with the self-swab that when we're discussing it, we'll take it out, and it's a really one-on-one conversation between the provider and the patient, and that has been very helpful with the comfort level of the test, and then patients more willing to screen for HPV. The biggest issue that I see with patients is that when they do screen positive and they have to come back and get that speculum exam, that can be very disheartening for them and bring some of that trauma back. But when we're presenting the test initially and we say this is a possibility, if it comes back positive, we'll have to have you come back, then that usually helps quite a bit in easing some of that fear. I think that's it. That's all.
Dr. Halley, you were going to comment also?
Yeah.
Yeah. In terms of staff, I think, providers, there are some providers who are more kind of detail-oriented about research, and others who are more inclined to kind of do what they think is going to work best for patients. Not that those are mutually exclusive, but in the training video that we had for both providers and MAs, we really emphasize that FQHC patients have almost half the amount of cervical cancer screening to the general population, and then talked about the specific barriers that our patients have and how this is an option that can overcome those specific barriers. And, everybody who works at HealthPoint is mission focused, and they want our patients to have good care. And we also talked about how self-collect is used in over 25 countries, both resource rich and resource poor. It's been approved by the World Health Organization since 2021. So I think just in the training, we kind of were able to get people focused on the mission and assuage a lot of the concerns that possibly people might have had that this is like new. And by saying it's actually not new, it's new to us, but it's not really new if you look worldwide.
Thank you. Thank you so much, panelists and attendees. We had a lot of great questions today. A few we didn't get to, but we'll follow up with answers within the next couple weeks. There will be a recording of this call on the Roundtable website in the next few days. We have one more webinar coming up. Join us during Cervical Cancer Prevention Month in January on the 15th. And that will really get into the implementation piece, which I think everybody's very interested in. Lily will drop a link in the chat for you to register for that now. And lastly, we're asking that you take a moment following the webinar to complete a 5-question evaluation of the session. It'll pop up for you when we end the webinar in just a second. We certainly hope this session provided useful information that's applicable to your daily work. Thank you so much for joining us and have a wonderful day.